comorbidities are more vulnerable to COVID-19 complications. Cancer itself is a major public health problem. Its burden continues to grow globally, exerting tremendous physical, emotional, and financial strain on individuals, communities, and health systems, specifically in middle and low-income countries, which are least prepared to manage its consequences. Pooled analysis from a large series of studies has so far indicated that approximately 1 to 3.9% of COVID-19 patients had history of cancer, and the rate significantly increases among those who were critically ill and died. On the other hand, ongoing research on cancer patients has illustrated clearly that they are more and have significantly higher chance of getting COVID-19 infection. The risk can reach to up to 8%, and they tend to have much worse outcomes. The American Society of Clinical Oncology demonstrated that patients with active cancer and progressive diseases and those with lung or thoracic cancers who had received chemotherapy or immunotherapy within 3 months prior to the diagnosis of COVID-19 had registered significantly higher rates of deaths, and they tend to have much worse outcomes than those with cancer remission. In general, the unprecedented burden of the pandemic on the health system has disrupted the full spectrum of cancer care, not only through delaying diagnosis and treatment and halting clinical trials, but also through posing great impact on all other aspects of cancer control, starting from prevention, passing through screening, palliative and supportive care strategies. Nowadays, the oncology community is actively working together to face that problem, emphasizing that in order to assess the longer-term impact of COVID-19 on cancer care globally, we should focus on the current normal for oncology service. So how is that? To avoid risks of infection, cancer care should be adapted to reduce the time spent in hospital settings. So if there's an essential appointment, special safety measures should be placed to ensure protection of the patients and staff. And in many cases, it will be perfectly safe to delay some diagnostic or screening procedures or even some treatment protocols. The European Oncology for Medical Society laid out recommendations on cancer care during the pandemic, concluding that if a patient with cancer developed symptoms of COVID-19, then the medical priority will be to isolate and treat the infection rather than the cancer, which could be managed after recovery. On the other hand, if cancer treatment has to be continued, then careful consideration of the risks versus the benefits of any intervention should be carefully explored. However, when predicting the sequelae after applying this practice on a long-term basis, experts warned through the Lancet Oncology that the next several years could bear witness of thousands of additional cancer-related deaths that could have been prevented through routine cancer care practice, which was delayed because of the pandemic. So what does the WHO advise in that respect? To elaborate comprehensively on this serious dilemma, we have the pleasure of inviting two distinguished speakers from WHO. Let's welcome together Dr. Slim Salama, Regional Advisor from WHO EMRO, and Dr. Andre Ilbawi, Technical Officer, WHO Geneva. I would like to introduce the first speaker now, Dr. Slim Salama, who will focus on the impact of COVID-19 on cancer care in the Eastern Mediterranean region of WHO. Dr. Slim Salama is a medical doctor specialized in internal family medicine and global health. He currently assumes the position of Regional Advisor in charge of NCD Prevention Unit in the Universal Health Coverage, NCD and Mental Health, WHO EMRO. He contributes to providing strategic and technical support to 22 member states countries in the Middle East in scaling up their efforts towards prevention and control of non-communicable diseases. Part of his work is also dedicated to strengthening WHO normative and technical support to countries affected by humanitarian crisis. So please, Dr. Slim, most welcome, and the screen is yours.
Thank you, Professor Alwan, and I would like to also extend my warmly thank to our dear colleague, Professor Salman Rawaf, and for the organizer of the Arab Public Health Association for giving us the ability to contribute to this important webinar. I will immediately try to share my screen. So let me know if it works. Do you see my screen?
Yes.
Okay. So maybe as a disclaimer, as you mentioned, I'm not an oncologist by training. I had a background as a medical doctor of internal medicine from Geneva University Hospital, where I worked for several years before joining WHO EMRO, and I have worked in many departments, including in oncology services. But as a disclaimer, I'm not an oncology specialist, and I will leave it also to my colleague Andre Ilbawi, who is an oncology surgeon, maybe for some of the point of discussion that merit more in-depth discussion. Regarding the outline of this presentation, we'll cover this following point. Maybe a very brief overview first of the cancer burden and capacity in our region. As Professor Alwan mentioned, we have 22 countries spanning from Morocco to Afghanistan, very diverse in terms of epidemiological demographic profile, but also in health system capacity. We also have a snapshot on the COVID in the region, specifically on also the impact of COVID on essential services, including, for NCD and cancer care, based on a rapid assessment that was conducted in June. And I would then elaborate a bit on some of the guidance, not only from WHO, but also from partner on maintaining essential services and specifically on cancer services, and propose a way forward. As you all know, the cancer has become, because of the demographic change and political situation in all countries, in all regions, but also in our region, a cause of important morbidity and mortality. We have more than 600,000 new cases of cancer per year, more than 400,000 deaths. This was the last figures of the global count from our sister agency, IARC. Cancer represents the second cause of death after cardiovascular disease, about 10% of all NCD-related death. And you have on the right side the distribution for male on the top and female having, in terms of priority cancers, lung, prostate, colorectal, bladder for men and for women, breast cancer being in the top 20 most common cause of death overall, beyond NCD and cancer. So it's really important, but also followed by colorectal and cervical cancer in this region, even if the incidence of the last one is less prominent than other countries. We expect, because of the risk factors, but also on the demographic change and the population aging, a dramatic increase of about a doubling of the new cases in the coming 2 decades. And it's one of the region from the WHO region that will notice the most important increase in cancer burden. So for sure, it has an impact on that population. It has an impact in terms of health system, in terms of ability also to reach out the SDG goals for health and reducing premature mortality related to NCDs. I just wanted to highlight on this slide also the contrasting figures between the burden, also the capacity, and there are different ways, of course, to assess the capacity. We have a global survey administered every 2 years that called the NCD Country Capacity Survey, that also integrate and include a certain number of questions on plans, strategies, programs on NCD, including for cancer, but also whether the countries have different element of capacity in terms of services, in terms of cancer registry. And you might say from these figures that you see now that most of our countries are quite in a good shape, with many, more than 70% of the countries have integrated NCD plan. Some of them have also included cancer, specifically 15 out of 22 have included specifically cancer as part of action plan or having a strategy or policy or related to that. Cancer program was also one of the most frequently referred vertical program for NCDs. And many of them have at least a cancer registry, but as we see, less than 70% have a really population-based cancer registry. So many other countries are still in collecting their data at the hospital level with a lot of fragmentation, and the quality of the cancer registry, even at the population level, is still something that we need to question. In terms of management, while many countries are reporting early detection programs, even at the primary care level for breast cancer, for cervical or colorectal cancer, even if they mention for the majority that national guidelines protocol exists for the management of the most common cancer, we still see that there was a gap also in the ability to have a full continuum of care where early detection is there, the ability to ensure timely access to secondary tertiary care and to a complete treatment, something that still needs to be overcome. And this capacity survey need really, it's one aspect of the picture. We often go to countries and we know that the situation sometimes differs from this kind of reporting, but I think it offers a baseline and an element of comparison, knowing that in our region we have different health systems with countries with very limited health system capacity, no specific plan or a strategy on cancer prevention and control. So significant variability between the GCC country, for instance, and other countries that are also in a situation of health system development or low level of health system development and low socioeconomic status. At the same time, and this is one of the challenges that I would highlight, that many countries are in political instability or facing emergency that constantly actually disrupt services. When you look at the availability of cancer diagnosis and treatment services in the public sector, these are the results, and we compare 2 years here, 2017 and 2019. Here again, it is a quite positive figure, but actually this, as I mentioned, need to be contrasted with the actual situation sometimes on the ground that differ for this reporting. But you see that many countries are reporting, at least in specialized cancer tertiary care centers, availability of cancer diagnosis and treatment in the public sector, limited progress between the 2 years for comparability. But this is something, once again, that need to be reviewed in much more granular detail when we do the country assessments. As I mentioned, one of the challenges, we have several challenges that hinder the cancer prevention and control in our region. The political context with a lot of political instability, humanitarian emergencies, and you have seen even recently the situation like Lebanon, when you have the political instability plus a disaster that happened on the top of that, how things can really get worse. Still, despite the fact, as mentioned, that we have some data on the incidence and the mortality, sometimes a mismatch between the strategic direction, the prioritization, specifically on balancing screening program versus early diagnosis, and the prioritization in terms of investment to make sure that the cancer continuum is addressed. Insufficient attention to preventive measures in terms of early detection, but also in terms of population level intervention like tobacco control to be able really to address the root causes of many of those cancers. Limited public awareness, stigma also very profoundly still a problem in our region. And even when services are available, like in many of our Gulf countries, the uptake of preventive services is still limited, which all this actually leading to late diagnosis of cancer, which is already something that we're struggling with, so let alone when an emergency occurs. And as I mentioned earlier, the early detection strategy, when sometimes cancer screening programs are put in place, they are mainly opportunistic programs with limited impact and evaluation, external evaluation of those programs. The high cost of cancer medicine and technologies, sometimes because of the investment, but also because of the inability for many of our countries to really negotiate prices with companies. And there is a lot of issues specifically for third-line therapies, for monoclonal antibodies, where actually many of our countries pay a high price of those medicine and technologies. And of course, for many of those programs, the health system development themselves in terms of health information system, the health workforce development are not sufficient enough to sustain quality services. So we start with multiple challenges at the same time. I mean, many countries have made some strides in this situation. We'll just now move to the situation of COVID. As you know, I mean, since February, this is the curve, the AP curve, and you have on the left side the color code of the 22 countries. And you see, I mean, that the curve, we are still not completing and controlling entirely the pandemic. More than 1,800,000 cases, cumulative cases since February, almost 50,000 deaths with a crude fertility rate of 2.7. And you have seen that over the summer, with also the change in the public health measure, opening of the airport, some relaxation of the public health measure for public distancing, curfew and lockdown, we have a resurgence of some of the cases in several countries. So we are still within the pandemic and following this very closely with our countries. I would like now just to present very rapidly a rapid assessment questionnaire that was sent to our Ministry of Health focal points that were already involved in the NCD country capacity survey that I mentioned earlier. And those questions were really to address how much the COVID pandemic have disrupted NCD services, including for cancer. We had quite a
Dr. Salim, the voice is not clear.
Yeah.
Okay. Do you hear me now?
Yes, much better.
Okay, I will maybe speak louder and near to the microphone. So we have quite a good response rate for this questionnaire. I just highlighted few of the results, and the report will be soon available on our website if you want to have a view. So basically, we see that more than half of our countries have mentioned whether complete or partial disruption of all type of services. In the case of cancer treatment, more than 40% of cancer services has been affected by the pandemic. For many aspects, the cause of disruption, I will detail them in another slide. Maybe here we can see also that both outpatient services and inpatient care has been affected. About 16% of our countries have closed the outpatient services, mainly because of public health directives. Several others have...
your voice, please.
Do you hear me?
As well.
Okay, I will try to speak without the speaker.
Yeah, much better.
Okay. So as I mentioned, both outpatient and inpatient services has been severely affected to some extent because of the situation of the lockdown and the measure taken by countries to limit mobility. So if we look at the next slide, the most common causes of disruption has been to some extent the triage and the decision taken to limit inpatient access to hospital and services with postponing, elective consultation. So this has been the most frequent causes, but also the closure of outpatient services, as I mentioned, because of the lockdown, the public health measures that limited ability of personnel and patients actually to reach out to the services. Other elements are also related, and we have seen it in our region, about the fears from patients, the inability also to protect, to offer PPEs, to be able to adapt the services in a way that protect both providers and patient, and all the causes that are listed here on the left side. In order to overcome this, several strategies have been put together for NCD management, and for cancer, we'll see in detail other aspects. But basically, a lot of the decision has been in terms of triaging to identify better the priorities, try to postpone, delay, or adapt the services. And in the case of adaptation, maybe less for cancer, but also the use of different way of service delivery, including digital health technologies and telemedicine as a way to replace person-to-person consultation in many of the countries, but specifically for those countries that have, that level of system development, as I mentioned. And if we do an analysis of this by country grouping, we'll see that specifically in the GCC country, some of those countries have already had the ability to use virtual clinics, while there are other countries actually the substitution wasn't there. It was also one of the challenge. One of the questions also is the availability of data, and some of the countries, of course, that are reporting to us the data, but we have been struggling in particular to have enough data on COVID and NCDs, and some of the point that Professor Alwan presented in the introduction. I just here mentioned one article that have reviewed the current evidence of research on cancer patients, highlighting these 4 elements, aspect related to the effect cancer therapy on COVID patient, but also the particular profile and vulnerability of cancer patient to COVID, the outcome of cancer patient also infected by COVID, and increasingly the number of paper that we see also in our region now emerging are recommendation or strategies for risk reduction and management of cancer patients. So how we maintain services for those patients that are in need, and how we do it in a way that protect them also from the infection and ensure that they have access to timely and effective treatment. And this is perhaps this point that I would like to elaborate on. Many of our response are articulated within a framework that is wider on strategic preparedness and response for COVID. There is a global plan that has been issued by WHO to support countries at a regional level. We also recently just released the 2nd edition of this COVID strategic preparedness and response plan. Why I mention this is that until recently, one missing element was really important that have not been still addressed yet, is the issue of maintaining essential services, what we call the Pillar 9. These strategic response plans were built on 8 pillars, but most of the pillars were focusing more on the COVID management, the ability to have infection and preventive measures, to detect the cases, to trust the cases, to provide case management, including ICU management for those complicated cases, but limited actually support and guidance had been given until recently for maintaining essential services, including for cancer care. So in March and most recently on the 1st of June, WHO has issued this interim guidance, called operational guidance for maintaining essential services during an outbreak. I will not dive into the detail of this, but I just highlighted here there are 2 parts that are important part in this document. The first one are these 9 elements about governance and coordination, how you organize yourself to be able actually to have a coordinated response between providers, institution, and identify context relevant essential services across a range of bundle of services and to prioritize those services. What are the service delivery settings and platform, including infection and prevention control adaptation that are required in order to deliver and to maintain continuity of care? How do you establish patient flow, screening, triage, and targeted referral when you decide actually to maintain, even for patients that require specialized care like cancer, patients living with cancer? And those adaptations actually are further developed in the guidance. How do you manage health workforce capacity for also protecting them, but being able also to assign or reassign some of the health workforce, not only for the COVID response, but also to maintain those essential services. There is the issue of essential medication and equipment, and we have seen that COVID had an impact overall on the supply chain at the global level, sometimes for API that has been, for generic medication produced from India or China, but also at the entry point in countries when the supply for COVID has really skewed and has somehow diverted attention from other importation of essential medication and drugs. There are also the reinforcing the message about financial barrier for people who have also lost jobs, and all the economical aspect about supporting people, not only in terms of providing availability of services, but also the financial barrier, an important element for many countries where out-of-pocket spending were already, prevalent. An important element has been about the risk communication, how you adapt and communicate with different type of patient and the general population, but also on the use of digital technologies as an alternative model to support appropriate continuity of care for appropriate services. And the last point is really an important one also about health information systems. Many countries have deficient health information system, and continuity of care for chronic management in particular rely on a strong information system. And this is what we have seen in many countries, that even an ability to reach out to the patient, to inform them, or to be able to have a register of patients that allow countries to plan and divert those patients on alternative pathways. So the second part of this operational guidance had been somehow overlooked, but it provides specific consideration and adaptation required to maintain essential services, including tables that give at least an overview and some principle about specific services, including for specialized care for cancer. So I will not enter into the detail of this, but basically it offers some support for countries to be able to consider and prioritize cancer as part of the overall, task of essential services, continuity of care. Of course, the guidance are not just coming from WHO, and a lot of professional societies, as you alluded to in the introduction, Professor Alwan, have also came out with recommendation. And just here again, put a review of international early recommendation that are focusing on these 5-element epidemiology of cancer diagnosed in more advanced stages in this country. And one aspect of this review, I have made an error here, but this review look at different elements about cancer care in different departments on the 3 modalities of care: for surgery, for radiotherapy, for medical oncology, looking also of the adaptability of the international recommendation to low and middle income settings. And one of the take-home message is that, of course, in our countries, many of those recommendations that you alluded to from the American societies or from European others can apply, but we need to take into consideration that the epidemiology of cancer is more advanced in many of our countries, that there is a limited capacity already pre-existing sometimes to manage those cancers. And many of the COVID center or the hospital that had been redirected for COVID centers might also push some of the cancer treatment, and the centers that are offering cancer treatment that offer also centralized in capital, so might also contribute to this delay. Without mentioning also the economic impact in terms of prioritization of health system priorities within this context. I'm sorry, I have just copied twice. This was the message, but the previous slide just detailed the content of this review. That's quite interesting because it compares several recommendations at a global level for cancer adaptation, but looking at the adaptability for our context. We have also regional experiences. I just mentioned here, our colleagues and Professor Khoja might comment on this. Saudi Arabia has been also experiencing MERS-CoV, and there is some lesson learned from past outbreaks that have been also used in the current context to adapt the oncology services during the current outbreak. Several professional societies, academic institutions, and MOH have come together. Just to give an example here of 4 countries. We have from Morocco, a group of oncologists that have adapted the guidelines. I have made some recommendation for adaptation of cancer services in Morocco. We have a statement and further development. It was early March already by our Lebanese colleague on Society of Medical Oncology on the care of patients with cancer during COVID. And we have several guidelines, quite detailed, from our Iranian colleagues. There was an initial one on the top, but then there was been a different type of adaptation of consensus on cancer adaptation. So I think one of the messages there are need clearly for adaptation. We are learning by doing. There is a need to contextualize much more perhaps those recommendations when it comes to countries based on the health system development and the services that exist in those countries. So one of my last slide about the way forward, I think we have really an important work still to identify and include cancer as part of essential health services to be maintained, as I mentioned, to this pillar 9 from the COVID country strategic preparedness and response. We still see that that continuum of care is quite vague in many of the countries and the plan. We need also probably to better understand the profile and the outcome of this specific population. We have a lot of countries that are included in clinical trials that are reporting on the COVID form using standardized WHO form. The comorbidity section is often not filled specifically also for cancer. We need perhaps to better document, understand the impact on cancer services as part of the monitoring of disruption of services in general, but also in terms of case studies when countries are really trying to put in place guidelines. As I mentioned, there are several examples in the region and beyond. The guidance that I mentioned earlier, the interim guidance on maintaining services, I think it's a good entry point to structure the discussion around what should be done. And this cut across many services beyond cancer. Of course, as I highlighted, for cancer specifically, there is a prioritization exercise that is specific to this condition, but there is other element that really cut across several conditions. One aspect that really was specific for this COVID response in comparison to other emergencies, because we are living in a region of emergencies, was really the use of digital technology as an alternative model. We need to document this further and see what kind of guidance our countries request to be able actually to reuse this in the future. And the last point, but not the least, I mean, is really to build better. And building back better means that learning from the current situation to be better prepared. And in a situation where we have half of our countries in emergency, something that we have learned is that there is this nexus between humanitarian and development that we need to bridge. And there are different ways to do that. One aspect is really to go back to the basic element about the prioritization. And I'll just refer here to the World Report on Cancer that Andre and her team has put together earlier this year. I think many of those recommendations are still valid in terms of prioritizing a set of evidence-based intervention and being able actually to contextualize those interventions, taking into account the health system requirement of different countries in our region. And to support this, we have a certain number of guiding documents in the region. One is the regional framework for action with some tools also to support implementation. And we have a quite large range of support specifically to countries. I think the difference will come only when we go to countries, when we closely work with the colleagues on the ground to be able to understand the situation. So some aspects are related to cancer policy and prioritization, like in Afghanistan. We had an impact mission last year, and we are trying to develop the first national strategy on cancer. Sometimes for more developed countries, like in Iran, we have a review of the cancer care pathway, or in the situation of Saudi Arabia, a review of screening program, where many countries in the GCC haven't had really an external evaluation of the screening program for years. Even a situation in emergency like in Yemen, being able to procure essential cancer medicine and maintain those procurement, even for National Cancer Center like in Yemen, we have been working with them since 5 years in trying to maintain, essential services, the same from Syria. And more recently, we have done a comprehensive assessment of the health workforce and technology assessment for Palestine, where also there was a revision of the national strategy. So a huge range of intervention that require a lot of expertise and also a lot of partnership with colleagues and professional association in the region to be able to move and to move away also from this outbreak, inshallah, and be able to restore those services, but also to strengthen overall cancer prevention and control. Thank you. I just put here some selected references. Some of them are used for this presentation. I'm happy to take any question if you want to contact me.
So, thank you very much, Dr. Slim, for the very informative, interesting presentation. And now we will move to the second speaker, Dr. Andre Ilbawi, who will focus on maintaining essential cancer care during the pandemic, global perspectives, current impact and response. Please, Dr. Ilbawi, the screen is yours. Thank you very much.
Thank you, Professor Alwan, for the introduction, and thank you to Professor Salman and the Arab Public Health Association for the invitation to participate. It's an honor for us to support the dialogue in the region, for which we have seen many relevant case studies and best practices. Also, it is a privilege to speak alongside my dear colleague, Dr. Slama, and his experience in the region. So thank you very much. To begin now by sharing the screen. As Professor Alwan has highlighted, we'll focus now on the global perspective. What have we learned? What are we seeing in some countries? And what do we anticipate as we look to the months and years ahead? As we've heard, we have to start with the question of why cancer. We are not the only disease that has been impacted negatively by COVID, but there are very relevant features that we can learn from cancer that perhaps are a tracer within not only the NCD portfolio, but also for the broader health system. To begin, cancer is a very common disease at the global level. We know that each year, more than 18 million people are diagnosed. But to make that number a bit more personal, we can say that in a high-income country, 1 in 2 men and 1 in 3 women will develop cancer in their lifetime. That is 1 in 2 men or 1 in 3 women. So every family undoubtedly will be impacted by cancer. And in low and middle income countries, the ratio is still quite severe, 1 in 5. This is only going to increase over time, as we heard from Dr. Slama. But from a public health standpoint, we also have to ask, when we see clinical services, is cancer that common? If we look at the broad portfolio of what are the diseases seen in primary care, we see that in fact, cancer as a new diagnosis is actually quite rare. Most communities, most clinics are dealing with hypertension, respiratory tract infections, pneumonias, tuberculosis, parasites. So we are within the cancer portfolio at this interesting nexus where cancer is both significant and personal, but also quite rare in primary care services. What we then have to conclude is that cancer is a major event in the lives of individuals and communities. And the system from primary care through specialty care, community-based care to palliative care must be ready at all times and in all circumstances to respond to the cancer burden. So here's what we'll highlight in the next 15 minutes. Reflecting on the global setting, what is the current interface of cancer and the health system in the current COVID pandemic? And how has COVID, in fact, helped us understand some of the vulnerabilities that have been there, some of the vulnerable populations that have been for years left behind, and now we're seeing it even more severe. Then, as Dr. Slama has done, we'll move to the question of what can we do? What can we do, but with what measures of caution do we need to consider as we move forward in this community? For us, it is a pathway, the cancer care continuum, as Professor Alwan has said, from symptom onset to survivorship care or palliative care and death. Cancer is not an event, it is what ultimately becomes a life journey for most patients and families. When we think about that life journey, there is a pathway. The symptom starts, a diagnosis must be made, treatment is initiated, treatment must be given in a high quality and in a very standardized approach. And then of course, people have to regain health to the fullest extent possible and reintegrate into their families and their communities. So how does the system support this? Looking at, as we know, at the health system building blocks, and also thinking of the broader functions of the health system, not only how many people will live after a cancer diagnosis is made, but have we promoted equity? Is the system responsive to the needs? Oftentimes we're addressing what we think are the priorities for cancer patients and not recognizing that oftentimes cancer patients are not seeking the 5th, 6th, or 7th line therapy. They're seeking a system that can respond to their needs, quality of life, end of care services, and other supportive care needs. Now, before COVID, as we've heard, the global baseline was quite. We knew that in most countries, because of a lack of investments in primary healthcare, most services for cancer are delivered in specialty centers, a very fragmented service delivery model. We knew that the workforce was severely limited. In high-income countries, one oncologist may be tasked with caring for 200 cancer patients per year. In most countries around the world, this ratio is on the magnitude of 10 or 100 times worse. One oncologist trying to manage 2,000 or 5,000 cancer patients. And that is also to say on the oncologist is only one of over 200 types of providers that are needed for comprehensive cancer care. Governance. We know that cancer plans may exist. Most countries have cancer plans, but they often aren't implemented. They often lack accountability measures. They often are not budgeted. As Dr. Slama has mentioned, registries are weak, and this continues to be a major challenge. Weak registries often relating to poor decision-making. Cancer care is expensive, we know this. It does not have to be, but unfortunately in many countries it is. And the ultimate consequence is that many patients are suffering financial hardship. Selling homes, selling possessions for cancer care. This is before COVID. Now, we know that we have seen the outputs. We have seen this described in the literature. Most countries have late stage disease. Most countries don't have sufficient services, as Dr. Slama has mentioned. Quality of care is a major area of concern. And of course, there are problems with survivorship care. Now, here we are in 2020. We have all suffered a severe and profound shock in this current pandemic. And let us also pause and reflect on how much this has touched our own lives, our communities, and people around the world. We appreciate the Arab Public Health Association for being at this front line, because this is really, as we know, a once in a lifetime. We fear, we don't know, but this is unlike anything we've seen before. And we know that cancer patients had already been susceptible and vulnerable, and now we see it's even more severe. Delays in diagnosis worse, people not being able to access care, care not being available, affordable, supply chains being disrupted, the list goes on and on. So we then ask our question, what can the health system do? What can we in the public health community prioritize to change this? And as Dr. Salman mentioned, to build back better. So we have to look at it through a very detailed root cause analysis. It is not enough to say, well, there aren't people coming for cancer care. That is an obvious output, but why? Do we know why people aren't coming for care? Is it perhaps because they're in quarantine? Is it because they're afraid? Is it because of their financial situation? Is it because the bus isn't available? We have to break that down and understand, because if we're going to propose solutions, understanding the root cause is critical. So we can see in that patient pathway, there are problems across the cancer pathway. And here are some listed. For the sake of time and to ensure we have an opportunity for discussion, we will just share with you some of these preliminary findings. But as we know, there are very severe problems. Diagnostic volumes decrease significantly. Staff being detailed to other services, including COVID, not being available, or themselves becoming sick from COVID and not being able to continue offering cancer services. Treatment alterations, either by choice or by necessity, because unfortunately, many people are unable to access the cancer medicines or services that they need, and of course, high rates of treatment abandonment. To get a better understanding, as Dr. Slama has mentioned, through WHO, we've done surveys, and we've also noted with great interest that there are groups that are publishing both their experience and some objective data on whether or not cancer services have been disrupted and how severe they are. So we've done a systematic review to capture this and help the community better understand. We found 62 studies to date that have described the extent of service disruption in only 10 countries. So unfortunately, there is a high limitation in only effectively 2 countries were there data from low and middle income World Bank status. This is a major problem for us to understand what is the consequence in those low and middle income countries, but nonetheless, it was quite informative to see that there were over 38 different types of disruption identified. And you can see, in fact, that most of the studies to date have focused on the provider or system related issues. Is the service still available? Yes or no? Are the medicines available? Yes or no? But we are also lacking the necessary data on the context related factors. What is the impact of quarantine measures? Has that been the cause, the root cause? We've also found that many are structural measures. We don't have a good sense of what are the downstream process or outcome indicators. And these are very relevant because a delay is not always a fear or a poor outcome. There are delays that are tolerable. Of course, the objective with cancer care is to get treatment initiated as quickly as possible. But if you have a low-risk breast cancer, waiting 1 extra week may not be a problem, especially if that means you can access care safely and affordably. So what are acceptable delays? These are why we found that the data to date has been insufficient to adequately describe what is a disruption and has this disruption impacted cancer outcomes in a negative way. But we know this is just the beginning. We can begin to already estimate what are some of the other factors that we need to get a better understanding of and describe. So we know that delays exist. Why is that? Is it because of poor communication, as we'll talk about later? Is it because primary healthcare services have been redirected or are closed down because of quarantine measures? These are important causal factors to understand. And most importantly, to start looking at the next step. What are we going to do about it? Because of course we know that the problem is complex, but we also know that the solutions will have to be multi-sectoral, they will have to be well articulated, and they will need broad stakeholder buy-in for them to be effective. Are we implementing and measuring effective solutions? So let's get into that question of what are the solutions. If we go back and look at this context, what are the preconditions of an effective response when we look at surge capacity in a health system? We know that response has to be multi-sectoral, it must be data-driven, and it must be founded on a workforce because we know people are at the front line and these are the people who are going to be asked to do more when they're already being stretched to the fullest extent. So when we look at that root cause, we can really break it down into 3 different effective types of solutions. And I've listed them here, but rather than go through them, let's individually describe them. If we look at these solutions, we also have to recognize that solutions will change over time. They will change by health system, and they will also, of course, change by the capacity of that system to respond in different surge scenarios. As an overview, we see that the response in high-income countries has been quite efficient. For example, in the UK, very soon after the pandemic took hold, they made a priority setting exercise in which they said, these are considered essential services that we want to focus on. And they also created COVID-free cancer hubs. Now we're still trying to understand the impact on services because it is very difficult to maintain a quote unquote COVID-free cancer hub, but this was the type of exercise that they did. Stakeholders at the table used data to inform policy and measured the impact of their implementable solutions. Similarly, in the Netherlands, we saw, going back to one of the root causes, poor public awareness, or perhaps some fear. So in the Netherlands, they reached out and they said, please, if you have any cancer symptoms, don't stop. Come to see your primary care provider, contact your primary care provider, depending on the setting, and have that discussion. Do you need a diagnostic evaluation? And they saw the decrease in new cancer diagnoses abate. And this was a very effective public health measure to address what was identified as a root cause in the country. Now, when we look then at those 3 types of interventions, first, how do we maintain core services? In order to do that, we have, as Dr. Slama has pointed out, the foundational task of identifying what is essential. Because we can't just call every cancer service a core service. That would be inappropriate and unfair given the complexities of the health system and its response to the current pandemic. Not every cancer service is essential, but which ones are needed tomorrow, not in 3 or 6 months. And as you can see here in Latin America, the WHO Office of the Americas, known as PAHO, has produced this type of guidance. What are considered the high priorities and what are considered the lower priorities. And a similar exercise has been done in the childhood cancer community by adapting guidelines and helping both providers and policymakers understand what is a core service in cancer. Second, the importance of communication, and this cannot be understated. When we actually look, and this was something we did informally, but if you do a Google search to see COVID, there are, of course, billions and trillions of hits. But in fact, 1 in 10 Google searches on COVID is related to cancer. And that just shows how important cancer has been in the global dialogue in the response to COVID. It is on everyone's mind. What am I going to do? Is my care going to be available? What's going to happen to my loved one? And the advocacy has been both positive, but also negative. There has been some unnecessary fear that services are going to be rationed, that people are going to unnecessarily die. And this circumvents an evidence-based and data-driven discussion that is needed. We cannot adhere to an open discussion that lacks the necessary data and scientific findings to have an honest and transparent advocacy dialogue. And when we do this, of course, we have to engage the community, because identifying core services is not just about public health officials and cancer specialists sitting at a table and saying, we think this is the most important, but the patient voice is of course needed. So how do we engage that patient voice from the beginning? And then what do we do in terms of service delivery? We know the importance of primary care, primary health care as a community. What are we doing in cancer to reinforce that importance in this setting of the pandemic? Is our response, let's just do everything in our cancer centers and avoid what's happening in the community? That can't be the response. So of course we know telemedicine is important, but how do we start looking at patient flow? How can we operationalize the patient pathway and referral mechanisms more efficiently? And as we'll talk about shortly, this is in fact some of the best data we have to date. Not so much the impact of telemedicine, although we know many communities are using it, but rather how cancer providers are linking with primary care, are linking with each other to maintain effective service delivery models. And this is an opportunity for us to build back better. Because if we can improve that service delivery model in the setting of a pandemic, that gives us the motivation and the confidence to do it afterwards. But there is some caution. Not all solutions are the same. So as a second systematic review, we want to look at what are evidence-based mitigation strategies so we can share them. We found only about 10 studies. We know that every professional society in cancer has published what they think we should do. But in fact, many of those recommendations are discordant, and very few of those societies are helping measure what is the impact of their proposed strategy. And that is a problem. Because if we saturate the community with try this, try that, and we do not have consensus and we don't measure the impact of our mitigation strategies, then we will be at the whims of those who have the loudest voice in the room and not those that have the science to back their proposals. We've also seen that the global health architecture is fragile and is in fact getting worse. We know that NGOs in cancer are now being threatened in the current pandemic. Funding is drying up. The private sector is redirecting their priorities, and of course, understandably so in the current pandemic. But what does this mean? And what do we within the cancer community, within the public health community, want the discussion to focus on? Of course, we see that now cancer, public health, and healthcare has been politicized, but what are the points of reference that we can provide and stand behind confidently? Misinformation is everywhere. Are we over-relying on technology? Is telemedicine ready for prime time in cancer? Do we know? Are we ready to stand behind our proposals? And how can we ensure that we measure the impact of these mitigation strategies? And most concerningly, and of course we can discuss this for hours on end, we know looking at the systematic review as to who is who is suffering the greatest impact of COVID on cancer services, it's the same communities that have already been behind. It's the people living in rural communities. It's the older generations. It's those that don't have a spouse or family to support them. It's those that live in poverty. It's those that don't have a secondary education. And we know that it's only going to get worse. It was worse for them before the pandemic, and it's been worse now during the pandemic. How can we build back better with this lens of equity? So there's been a lot of questions. There aren't very many easy conclusions to make after a discussion like this. We know resilience is important for health systems. Have we been prepared? Are we prepared for what may lay ahead as we know new health system crises and emergencies will arise? Are we confident that we've been able to identify what are core and essential services? We feel confident, but this discussion isn't something we can do at the global level. It has to be operationalized at the country and at the community level. And how can we acknowledge that risks may happen, and in fact are happening, but how can we mitigate those delays and ensure that cancer patients aren't being lost in this global response to the pandemic? It is possible. We've seen it successfully in some countries. How can we translate that across other countries globally? We look forward to the discussion. Really, thank you again for the opportunity to present.
Thank you. Thank you very much, Dr. Andre, for this comprehensive presentation. And for the participants to know, Dr. Andre is a medical doctor specialized in surgical oncology. He joined WHO Geneva in 2015 as a technical officer in the Department of Cancer Control Division of Non-Communicable Diseases, and in his current positions, he's responsible for implementing 2017 World Health Assembly Resolution on Cancer Control and Prevention, and he's the executive editor of 2020 WHO Report on Cancer, and he helps lead WHO Global Initiative for Childhood Cancer. Thank you very much, Dr. Ilbawi. Please, Professor Salman and Professor Khoja, the floor is open for the panel discussion.
Thank you, Professor Nada. Thank you very much indeed, Dr. Slama. And thank you, Dr. Andre. Thank you very much indeed. I really enjoyed the presentation. I know we took a little bit of more time than allocated, but never mind, we truly enjoyed it. Some colleagues remind us about the timing, that's fine. I think the issue here, before I go to Professor Khoja, the issue here is extremely challenging. And challenging for the health planners, challenging for those in public health dealing with a pandemic where the spread is so fast, dealing with a virus with a lot of unknown. The fear among the public, especially those at high risk and cancer patients are among them, is so high that because all of us dealing with uncertainty, we're dealing with a lot of unknown, you know, and you covered that beautifully, both of you, in your presentation and Professor Nada in her introduction. I think to me, and this came from some of the questions, there are 4 challenges the world must really meet or address, because COVID will be with us for some time to come. It's not something which is going to stop tomorrow and everything will be normal. I'll tell you, I mean, I found traveling yesterday to Geneva, I found it one of the most challenging experience I ever faced, you know, in terms of the sort of unusual measures taken by authorities, of course, to protect me and to protect others. You know, this is not something desirable, but it is essential in the current circumstances. Number 1, I mean, let me put these challenges that we are going to face. We already faced it, as a matter of fact, in many countries, is really the ability for patients to receive services free at the time of delivery. It's absolutely unfair now in 2020, approaching 2021, that in many countries, cancer patients cannot access the services because of cost. And this is, by the way, including highly advanced countries. Humanity, we the people living on this earth, should refuse that situation radically. And this is one of the failure of health systems around the world, you know. The second things, I think, Andre, you highlighted, the lack of specialism in the area and the number. I like that comparison between 1 in 200 and 1 in 1,500 in high-income countries compared with low countries. This is a huge difference. You're not talking about, you know, a small percentage in low-income countries. And this is serious inequality and serious injustice and serious lack of solidarities around the world. I mean, this is again came in other questions is, and I think you raised it, is the organization of cancer services in ordinary circumstances and today in an emergency situation, acute event like the one we're facing. You highlighted the example from the UK. They created a hub for cancer services. And this is a COVID-free system in this hub to make sure that the patients are confident in using these services. As you know, in some countries, all cancer patients, all those diagnosed with cancer, were shielded 100%. The term shielded, i.e. the government asked them, public health authority asked them not to leave home in any circumstances. In the UK, they provide them all the essential food, medicine, delivered to their home, to their addresses. You know, that is the term shielding. This is not isolation, different from self-isolation. All cancer patients fell in that category, irrespective of that age. Of course, there are other patients like immunocompromised, etc. So my question, I mean, to you, three of you and Professor Khoja, how can we move to a world where cancer patients and their families should not be worried about a treatment? Dr. Neda.
Excuse me, Dr. Salman, your voice was not...
I was saying, how can we move to a world where cancer patients and their families will not be worried about the cost of a treatment, and they know they will receive a treatment irrespective of the global situation?
To me, this is a very difficult question, specifically in low and middle income countries. You know, the financial burden, specifically now in the era of COVID-19. So to us, I think this question is very difficult. Definitely, we are trying to present services free of charge, specifically with regards to the treatment protocols. But I don't think that could be guaranteed, at least in low and middle income countries. I don't know if Dr. Slim Salama can add anything else.
Oh, yes, I can add a lot, but for the sake of the dialogue, I think you are raising, I mean, something very important, Professor Salman, about the progressive realization of the right to health in the specific field of cancer services, okay? And for me, the discussion is critical, but start with what we mentioned. How do you prioritize a set of essential services as part of the public benefit packages in a given country? Who organized this dialogue? How do we prioritize it? How the beneficiaries, the potential beneficiaries have their stake in the decision about get in this benefit package, not only in terms of access to availability of services in good quality, but as you mentioned, without enduring catastrophic expenditure at the point of care. And all this is the current discussion that we are having with many countries about investing in health as part of universal health coverage. And in many countries, we are discussing how do you expand the benefit packages when you have a very limited fiscal space? How do you prioritize this in order to maintain a bundle of services? And there is no need to be sequential. You don't need to invest in immunization campaign, and then when you reach that, you move to something else. You can invest in a bundle of services. An example, very concrete, in Afghanistan. We started the discussion based on an impact review mission about what kind of cancer services. Breast cancer was top priorities. We have identified palliative care and maybe a set of hematological cancer for childhood cancer. And we can start with that. And then you need to organize. There was only one center since 2016 that started to provide services. We need to build the system, but this doesn't come overnight. And I think my point is really, one is to get the dialogue right at the beginning in terms of prioritization within the UHC discussion agenda. And then example, trying by centers to support them and building all those blocks that Andre was referring to require time, but also technical assistance to look at the dimension about guidelines, health information system, health workforce training, and building this progressively. But of course, I mean, these are really discussions that are related to service delivery reform, healthcare financing reform, community participation, and all those elements are really broader discussion where the cancer is only one part of wider dimensions.
Andre?
May I add, Professor Salman, the problem is that in our countries...
Come back. Let's have Andre and you can come back, Professor Neda. Carry on. Andre?
Yes, thank you. These are great points. A wonderful background from Professor Alwan and Dr. Slama. To also give a context, the challenge we have, Professor Salman, When we look at a middle-income country, if we look at budget expenditure on cancer and do it proportionally according to GDP per capita expenditure on health, we see that the average cancer patient will have somewhere between $500 and $1,000 if we cover every cancer patient, all cancers. In the US, in the UK, one cancer patient is at least $100,000, often on the order almost of millions. So the magnitude is unfortunately impossible. The math cannot add up. So we start with two axes. One, value for money, the prioritization, and the other is efficiency of expenditure. Because we see many countries are also failing in pricing approaches where both for services, for workforce, and for commodities, where there can be significant saving. We look at the cancer landscape, we see countries that may have 200 cancer patients, 1,000 vials of a certain chemotherapy requested. They pay 10 times more than a high-income country pays. Why? So we should look at some of these efficiencies because we can in fact make progress. The starting point, as Dr. Slama has highlighted, is what do we want to prioritize value for money? That is the starting point in cancer. But we also can remember the axis of efficiency and how well is $1 spent. And that is where we also want to focus effort, because we know when we look at it, we see low and middle income countries are paying more for cancer products, and that is not acceptable. Just one last comment to close on. I think there's such value in what you said. This is, for us, a moral crisis. How can we accept a world where someone who's diagnosed with cancer, all the fear that comes with them, and then they have to sell their house, and then they sell their house for substandard care and they die 2 years later? This is totally unacceptable. So how do we come together as a community and say, this is what we're able to achieve with equity, with value for money as our guiding point in line with the commitments that the governments have made to date?
Professor Nada, you want to come back?
I will only, I will confirm the things that that the problem in our countries is that the health is not a priority in the agenda of the governments. And the expenditure on health is only 5% of the total budget. So if you want definitely the cancer care to be up to the standard, we should convince the politicians that health should be a priority. And that's our problem, as you know.
I mean, I really want to come back before I move to Professor Khoja, to Dr. Andre and what he said. I totally agree about priority. I totally agree about the issues both of you and Slim mentioned. But for God's sake, we have been talking about this, as long as I remember. I've been in public health for, God only knows how many years. I lost count. And every single WHO meeting, I almost attended most of the RC's meeting in EMRO for so many years. Every time, Slim may remember, we talk about health for all. We added now by all. We're talking about, securing the health for the nation. We're talking about equity. When's going to happen? When is going to happen? I mean, even the people start not trusting us because we are just talking about it. All these become like hot air, And I think it's absolutely essential to focus on these things and change it to some sort of reality. Professor Khoja, I don't want to go further.
Thank you so much, Professor Salman, and my respected colleagues, Professor Nada and Professor Salim. This is great, and the question is very crucial and very important. While I was heading the GCC for 16 years, this issue is a vital issue. What the Professor Salman raised is really a crucial for any healthcare system or any national development plan. So I think here he gives some answer, Professor Salman, while he's in the beginning of introducing this question. Unless the governments of put the healthcare as a priority and then put some special group as a priority. And this special group is the cancer group, the NCD groups, whatever the group we can name it. But I feel during my experience in the GCC, 67 countries, that we raise this issue as a top priority when we raise it to our leaders. So I think this is a message we can take from here, that unless there is a political engagement in this one and high leaders engagement in this one, I mean in the care of the cancer, we are doing just superficial touch in cancer care. So we need, as we did for NCDs, that New York summit, whatever summit. So we need, the government should in their cabinet put the cancer care as a priority and ask all sectors to participate, not only the Minister of Health. And this is what we came out with the Riyadh Declaration for. This is around maybe I'm Professor Salman participated in that conference 8 years ago, that we have what's called a Riyadh Declaration for cancer care, the economic aspect. So in short, I feel that we need a political support, and also we need to raise this one with evidence that what we are having right now in the cancer care is not actually enough, and it is what I can say, that it is underestimated, underdiagnosed, undercare. So by this, and also I urge the WHO, especially the EMRO states, the regional office in EMRO, to put this as in every agenda. I mean, in universal health coverage, in health in all policies. So bring this issue, which is a neglected issue, in all your policies, and the ministers of health look to this issue as a crucial issue. In the GCC, we are affluent countries, but even our patient came late, and as you know, Dr. Salim, in the tertiary, even in the metastasis, the cases are they have in the early stages, and some of the cases they are not managed very well. So what about the poor countries of Professor Nada? So I think there is a real need, in short, a political support in order to bring cancer care in the best way. Thank you so much.
We got a question from Professor Lubna Al-Ansari, and I must say, Professor Al-Ansari did not miss a single webinar of the Arab Public Health Association, and I'm one of the people who admire her and her contribution, significant contribution through WHO and across the region. Very logical question. Do we know if mortality and suffering of cancer patients increase with COVID pandemic? Do we have any baseline before and after? Andre, you have a global perspective. I have a UK perspective. I can add later.
Thanks, Professor Salman, and warm greetings to Professor Lubna. Really, we applaud and greet her. It's a true privilege to have her listen to this and ask such an important question. We do not have significant data to date. Registries have been reporting back to WHO what we have seen in changes in new diagnoses, but we have not yet seen what the consequence has been for death. We do not know whether it will, and what time horizon we will be able to measure it, because we know this will, as you said, Professor Salman, require a 5 or 10 year lens to say how severe the impact on COVID has been for cancer. Early suggestions are that they are going up. We just significantly. For cancer new diagnoses, we know that in many countries, it has been as high as 50 or 70% reduction in new cancer diagnoses. But the ultimate output or outcome of interest, mortality, this will take many years. If I can just make one brief comment, Professor Salman, and to Professor Khoja as well. What we're all talking about here is a political priority, yes. But I think, as you rightly point out, Professor Salman, let us avoid this, let's take it to our political leaders. We have to also go to the people. Because when we look at what become political priorities, yes, of course, public health experts, UN, this is an important platform. But we also have to encourage people to vote according to their own priorities. People do not express their priorities in health. They express their priorities on the streets as it pertains to economic or let's say security, but not as it pertains to health. In countries where we have had we see change. And this is also true in the region. When we look at the leaders, the politicians that get cancer, they can trigger a new phenomenon in cancer. Destigmatize it in Jordan, Princess Dina. We've seen what she's been able to do to elevate the cancer portfolio. We've seen Professor Alwan and the leadership that has been shown. Let us go to the leaders and also go to the community. We can't just go to every politician and expect change. We can focus on cancer legislation. It does exist. What cancer legislation can make a difference? We've seen it from Jordan, China, South America. What can we do in legislation that can change the horizon of cancer care? And at the same time, be cognizant of commercial forces that exist in this dialogue, because we know that this has also obscured our success to be able to generate a transparent and balanced narrative in where cancer fits. So just a few additional comments, Professor Salman, Professor Khoja.
I'll follow up this a bit.
Yes.
You want to come here before I got another question, Professor Neda. You have comments? No, Professor Neda, frozen.
Yeah, I just wanted to comment that according to our Dr. Salman, I cannot hear. Yes, I just wanted to add that according to our WHO dashboard for COVID-19, you know, up till now we have about 280,000 confirmed cases, about 6,500 deaths. Out of those deceased cases, we found that there are 45 cases of cancer. So the percentage is less than 1% according to our data. Definitely there are missing cases, but you know, roughly the percentage of those who died from cancer out of the total deaths is about 1% only, 0.8%, let us say. It's only 45 cases out of 6,500.
Yeah, okay.
So I think within the dashboard of WHO for COVID, we can find the answer.
Yeah, we don't have the whole data around the world. We don't know how many patients with cancer actually infected. Not every country is shielded their patients. We have a question from, which is a nice question.
Professor Salman, if I may, I just want to add just one point on the question of Professor Lubna. I think there are two dimensions. One is the mortality among cancer patients infected by COVID. The other aspect is what we call, in our jargon, the excess mortality, or the mortality above what would be expected based on the non-crisis mortality rate in a population of interest. So in other words, the ability to compare with past years, whether the COVID has added. I think this is an element that we have been struggling because of the civil registration system and our ability to capture. But in some countries, and we have seen it across the globe, have been comparison points showing that there is excess mortality in Spain, in the Netherlands. I think this could be an interesting way also to look not only on the direct impact of COVID, but also on the fact that the interruption of services might also contribute to excess mortality.
Yeah, thank you very much, Slim. Thank you very much indeed. We have a question from Dr. Naim Al-Qasir, another colleague who never missed any of these sessions and great contributor to this work. Is there any assessment of mental health impact on cancer patients, their families during COVID? I mean, I love to see some data on that. Anything, Andre? No?
No, I have not seen anything to date. This is a great question.
That's a great question. I didn't see anything in terms of the, all what I think some data from the UK did show that most of these patients were very happy with the shielding process. Because the government took control of the entire shielding process. They provide them with all medication, etc. And there was virtual. I know you, Andre, suggested that most of the virtual consultation were not subjected to proper clinical trials, etc. But at least they were some virtual links with these patients, because within a month, as you may know, that about 90%, because about 10% emergency, necessarily intervention, etc., continue to be either at primary care or hospital care. But in the UK, about 90% of all consultation in the initial stages move to virtual consultation, whether primary care or secondary care. And the patient is really, this is when we talk about engagement and participation. The patient did not put a pressure on the services. And I think in dealing with a couple of countries in our region and the Arab world, in EMRO region, I saw the opposite. I mean, if we saw a patient actually, despite the risk, they were demanding, putting a lot of pressure on the hospital, on services, overwhelming the staff who are doing fantastic job. So thank you, Dr. Naima. This is a great question, but we don't have an answer for it now. I have a couple of other questions. One is from colleague, actually his name is also on Andre. What do you mean by, I think one of your slides, COVID-free cancer hub? Can you, I know exactly what does it mean, but is it possible to explain it to the audience? Because this is a new concept.
Yeah, this is really quite innovative approach that the UK took about screening. Of course, screening everyone who comes into the hospital and limiting the number of people who come into the hospital, and in some settings, in fact, testing, so that they would test the night before and or a few days before and be asked to self-quarantine after the test, and will only be admitted to the hospital if they in fact tested negative. So there have been different approaches. In fact, the UK is not the only one that has tried it. We've seen some hospitals in the US and other high-income countries try really to effectively screen everyone who comes in, the workers and patients, so that to the fullest extent possible, patients that who have a planned elective or let's say sub-emergent procedure, cancer-related or otherwise, can be confident that in the hospital they will not receive an exposure or be exposed to COVID. So it's a very proactive mechanism, not just symptom-based, but often, in fact, including testing, which we know not all countries are able to do.
I mean, this is a good model, which, as you said, in some countries where actually patients were screened and sent home, they didn't, some of them even screened at home, but they asked them to isolate for about a week before they come to the hub. This is not simply because I was screened, I will go and see the hub immediately. It was really very cautious, and the hub is a green zone. Basically, you're talking about the green zone, yellow zone in hospital, and red zone for COVID-only patient. It was a highly sophisticated, innovative approach. And I think this is what we need, to be very honest with you. Now we know that we will live with COVID for some time to come. At least Director General of WHO said at least for a couple of years. Others are predicting even much longer period time. And we don't know. Maybe some people see it as an endemic, but we are not sure. Let me, in the last few minutes, just covering a few points about cancer services and how we should we move. One question came about the private sector and the role of the private sector in cancer services. And our review of what's happening in the world, many countries closed the private sector. Many countries did not allow the private sector to see a COVID patient, or indeed providing essential services. Certainly for cancer services, some countries don't allow the private sector to see cancer services. Private sector contracted to the public sector to provide a comprehensive cancer services. So what's your opinion about the role of the private sector during COVID for cancer patients? Slim, in our region?
Well, you know more than me the discussion that is happening, because we have even a range of consultation at the moment as we speak about the role of the private sector, which has been a point of the agenda even when our former regional director, Dr. Alwan, brought those elements on the table, saying that the private sector has been a blind spot in our eyes for years. So the ability to know what kind of services, the quality of services, the arrangement in many of our countries, 60, 70, 80% of the services are already provided by the private sector. So for sure, we cannot neglect it. Now, what is happening in the current situation with COVID, I cannot answer that question specifically about their contribution. As you highlight, we have seen that the disruption affected both the public and the private sector, also because of the measure that the government has taken. I think in countries where usually we have contracting services already in place, I think it was the only way to maintain those services. I think it seems very trivial, but many of our countries, as I mentioned about benefit packages, what pre-exists will determine what is maintained during an emergency. And in some countries where the private sector was the only way to get some of the services, I think they are still working, but I cannot have a very detailed account about the contribution during the COVID in our region. At the moment, we are doing an assessment in different programmatic areas about the role of the private sector. It will be one of the unique assessment, I think, across the WHO region about the private sector at the moment, but I think too premature to share results at the moment.
Dr. Andre?
Yeah, no additional comments, Dr. Salman. I agree. It has been a blind spot. We do not have good data. There are some countries for which we are seeing, unfortunately, wards close in public hospitals because the providers may be exposed or because services have been disrupted. And in those situations, we've seen governments turn to the private sector and contract services accordingly. There is no consensus response in cancer that I've seen, but it's a great point also for further discussion as we learn what experiences can be integrated into a new way of working in cancer, recognizing the deficit in cancer services is profound, from workforce to infrastructure, et cetera. This must be part of the dialogue moving forward, not just in the short term, as you said.
I mean, again, linked to that, I'll come to you, Professor Nada. Linked to that, I mean, is it logical that cancer services, which require very, very strict protocol of managing the care, this is about complex management of the care, is it logical to allow the private sector to take some part of the care, without the coordination? Because for cancer patient, the care need to be highly coordinated. Is it logical, Andre?
Please, perhaps Professor Alwan, to you first, and I'll make a comment. Another.
Professor Alwan.
No, really, it's Professor Salman. I'll make a brief comment because this is again an exceptionally important question. We know that quality is also a missing parameter in cancer care, and it is a highly specialized services. We are caught between wanting to decentralize because we know that patients will present earlier and they will maintain access to care and not abandon when care is closer to home. We know that cancer care is better when it's done in high volume centers, whether it be in the public or in the private sector. That is the inherent juxtaposition that we have not been able to reconcile. And frankly, we lack a robust policy dialogue to address that. And of course, to complicate matters further, there's also the parameter that cancer care in either the private or public sector, when is done in a highly specialized center, often gravitates towards the most expensive care. So what we know are there are 2 or 3 guiding principles. Number 1, standardization is important with oversight that includes guidelines, et cetera, coordination and referral mechanisms between centers. And of course, we have to look at how can we ensure that we get care closer to home as much so as possible. With those 3 principles, we are able to start making some coherent policies. But your question, again, is just absolutely essential. Think about it now, and let's think about it for the years to come.
We need to think in the last 30 seconds, we need to think about these. There are a lot of questions which we couldn't address. As always, we are victim of the limitation of time. Let me in the last few seconds to thank you most sincerely indeed for the most enjoyable session. Thank you, Professor Neda. Thank you, Dr. Slim. And look forward to see you soon. Andre, likewise, Dr. Andre, thank you very much. Professor Khoja, my dear brother, thank you very much. Thank you all. Next week, we hosting senior colleagues to talk about return to schools. It's a very important aspect of this acute event. And we look forward to see you again. Good night, good morning, good afternoon, wherever you are. I'll see you next week. Bye-bye.
Thank you. Take care.
Thank you, everyone.
Bye.
Thank you.
Dr. Andre, Dr. Slim. Thank you very much.